So it's time to start the afternoon sessions. So I would like to move to the session 4, ICT for health and welfare. So I would like to ask the session chair, Dr. Alisa. Can you hear me?
Yes, I can hear you. Thank you, Imoto-san.
Please.
Yeah, okay, I'll start now. So good afternoon, everyone. My name is Alisa Kongthon from NECTEC, Thailand, and it's my great honor to be your chairperson for today's afternoon session. First of all, I would like to ask everyone to please turn on your camera so that we can have group photos together, please. Okay, thank you very much. So for this afternoon session on ICT for health and welfare, we got 3 speakers from Indonesia, Thailand, and Malaysia. So each speaker would have 10 minutes for the presentation and 5 minutes for Q&A. The secretariat will help ring the bell. If you hear one ring, it means you still got 2 minutes to finish up your presentation. If you hear 2 rings, it means your presentation is up. You have to finish your presentation by 2 rings. And then after that, we have Q&A. And if you hear several rings, it means your Q&A sessions is up. And then we have to move on to the next presentation. So without further delay, I would like to invite Dr. Gelar Budiman from AICOMS Telkom University of Indonesia to please present his presentation on the topic of machine learning and compressive sensing for intensive care unit biomedical recording activities. Please.
Actually, this is about my research, and I'm going to have it with the project machine learning and compressive sensing for intensive care unit biomedical recording activities. The outline of my presentation is about the background and then the type of the patient's biomedical signal, and then the compressed sensing and why we use compressed sensing in these applications, and then the CS requirements and complete stage of the compressed sensing, and then how can we combine machine learning with this compressed sensing. This proposal actually according to the reason that from the ICU there are several biomedical signals produced, including video and audio, and then all the signals are monitored and recorded for hospitals documentation, and the status of the patient is transmitted to the nurse center, and then also we need storage for saving all the signal, all the biomedical signal, and then also we can predict the patient status according to the biomedical record. And then when the medical specialist is absent in the ICU, and the nurse have to take treatment to the patient, the nurse can take the decision what kind of treatment to the patient by the result of the machine learning in this application. And then also the specialist can read the patient status real time from remote. The status contains the real-time biomedical patient's data and the status prediction of the patients from the machine learning. Yeah, this is the type of the signal, the biomedical signal that produced in the ICU that will be analyzed and will be compressed by compressed sensing, and then after that it will be decided in what kind of status of the patient from this biomedical signal. We can now there are AECG signal, and then ABP signal, CVP, and then SpO2, heart rate, and audio and video of the patient's condition. Yeah, actually the compressive sensing or compressed sensing is a method to reduce the signal by a simple equation, yeah, in a matrix equation. So we can have a signal with with smaller size, but we just take it into one equation. So actually this compressive sensing will replace the conventional encoder, conventional compression encoder, and it is more simple than the conventional encoder in the encoder. But actually the reconstruction of the compressive sensing is more complex than the decoder of the conventional compression. But actually in this case we can make sure that the reconstruction is not mandatory to implement in this application. Why we use compressive sensing? Yeah, actually this is low complexity at encoder, and then it will become a fast processing encoder, and then it does not need much bandwidth. So we just need a much lower bandwidth, and then the reconstruction of the compressive sensing is not mandatory, since there are any machine learning which will decide the status of the patient of the compressed signal, and then the performance, the quality at the same subrate is not too different with the conventional compressing technique or H264. Yeah, we can see that the conventional compression framework and compressed sensing framework is different, and it is especially different in the encoding. That in the encoding, the compressive sensing is much more simple than the conventional compression framework. This is the requirements of the compressive sensing. We must have a sparse signal input to be the signal input to the compressive sensing. So the compressive sensing will efficiently compress the signal. And then we must have a restricted isometric property as a requirement to the CS. So the CS will have an efficient method in the process. And then we must have a compressible signal into the input of the compressive sensing. So with the compressible signal, the compressive sensing will have a very much effective performance. Yeah, this is the illustration of the sparsity, the signal, and the two-dimension shape, yeah, or image. With the DCT 2-dimension, we can see that the signal is changed drastically with the many variations of the signal will be changed to only a little fluctuation in the beginning only, but after the beginning and much more the length of the signal will be close to zero. So this is the sparse condition of the signal, and this is the something that the compressive sensing needs. So compressive sensing will have a good performance with this sparse signal. This is the complete stage of compressive sensing from the patient history, and then we do pre-processing, and then we do sparse forward in the signal, and then we do CS acquisition, and then the signal is transmitted to the server, and then in the server we can do the CS reconstruction, yeah, to have a signal back, yeah, and then sparse reverse, and then post processing. So we can calculate the data back. Yeah, this is the several reconstruction algorithm. This is the requirements of CS and machine learning. There are three: similar size compression, and then good quality reconstruction, and good accuracy. And this is the scheme that I propose, yeah, about this combination of CS and machine learning. This scheme, the second scheme, is the scheme that more efficient than the first scheme, because we do not have to do reconstruction in CS, but we can do compression filter before we use machine learning to detect or to predict the status of patient. So we can predict the status of the patient to a couple of hours or maybe several days before the time. So we can predict. So from the prediction result, the nurse or the doctor can do any treatment to return the patient status to the better status. This is the architecture of our proposed application. So from the patient, the biomedical signal is compressed by compressive sensing acquisition, and then it is transmitted to the server, and then from the server, the machine learning will detect or will predict the patient status, and the current and the predicted patient status is transmitted to the doctor, and also it will make decided treatment. So the nurse, when the doctor is absent in the hospital, the nurse can do the future treatment to the patient. Yeah, this is the conclusion. So we hope that our propose will help the patient, will help the nurse, will help the doctor. When the doctor is absent in the hospital, the nurse can do treatment as the result of the machine learning. So the patient will be better from the treatment immediately from the nurse when the doctor is absent in the hospital. Yeah, I think it's enough from me. Thank you very much for your attention.
Okay, thank you very much. Now I would like to give the floor to the audience for questions and comments, please. Any comments, any questions? Okay, I'll start first. Oh, okay, I got one. I saw Dr. Abu Shama, please. I saw you raise your hand. We couldn't hear you. Sorry. Still, I can still could not hear you, Dr. Abu.
Yeah, there is no sound.
Yeah, still cannot hear.
Okay, I can go first. Can you hear me?
Okay, yes, I'll move on to Professor from UTB, Brunei, please.
For the system, right, since it is applied to medical domain, this is very sensitive domain. And I think when you build the model, the generality of the model and the quality of the model is very important for the end user to use. I think it's a big challenge. The other thing is that when you do this, it must be a lossy compression, right? Yeah, it will be lossy compression. And I would think that the way you compress, it had to be domain dependent. It had to be application dependent, because when you compress something and you get it back, the data that you get it back, and if it applies to a certain domain, it look very likely that it will be particular to that domain, if it worked well for that domain. Now, if something changed along the way, I find it hard to believe that your model will be general. Do you think that makes sense? The generality of the approach. I would question that. I would question two things. The first thing is generality of the approach. Second thing is that how can you ensure the fidelity of the model to doctor? Because they are very particular about this.
Yeah. Okay. Thank you for the question, Prof. Yeah, the reliability of this model actually is already proved by several research. Yeah, actually, in our several research about this model, we also did the acquisition of compressive sensing, and then after that we do directly compression feature, and then after that we do directly in machine learning. There is training and there is testing, and we have good performance. It's
Okay, I also have the question from Dr. Abu Shama in the chat, and Dr. Abu Shama asks, how are you going to implement your project with your corrector?
Okay, thank you very much for the question. Okay, actually I will propose my project to my partner. Actually, I have a partner in the hospital, in the National Hospital in the Bandung, yeah, Rumah Sakit Hasan Sadikin. He is a doctor there, and we have a good relationship about the project. So we can start this project with her, and then anyone want to join this project. Thank you.
Okay. The time is up for this first. So let me move on to the second presentation. May I invite Dr. Vejjanugraha from Thai-nichi Institute of Technology of Thailand to give the presentation on No One Left Behind, automatic screening of rare and neglected cancer by medical image analysis. Please.
Okay.
Yes.
Can you see my screen? Okay, thank you. Good afternoon, all participants. My name is Pikul Vejjanugraha. Today, I would like to give you the presentation under the theme No One Left Behind, an automatic screening of rare and neglected cancer by medical image analysis. Our team member research consists of both the academic professor and also the researcher from both Thai and Japan countries. First, I would like to give you some past and ongoing research background with the medical image. So the first one is the fundus image. This one, we use the fundus image to detect the glaucoma in the eyes. Our motivation for the glaucoma in the eye because the progression of the glaucoma is very fast. If we didn't have the treatment within 24 hours in the advanced state or severe state, so it can be lead to the permanently blindness of the patients. So this is what we can detect from the glaucoma in the optic nerve head, the size of the optic cup and optic disc, and the ISNT rules. The second one is the HRCT lung images. This one is used a special technique called breath hold technique. Will generate 3D model with the end expiratory and end inspiratory when we breathe in and breathe out, and then we be able to generate the 3D model of it. We can generate the motion of the lung when it's expanding and shrinking, and then we can detect the emphysema, COPD, air trapping diseases into the 3D analytics. The next one is the malignant cells, which is the cancer cells. This one is the cancer cell in the advanced state when the cancer is already spread in your body already. So we get this cell from the fluid in our cavity in our body. So we can analyze the shape, the size of the nucleus, that is the normal cells or the cancer, and use the deep learning and CNN to classify this thing. Next one, the fourth one is, you can see this picture is our cornea. So this one we try to do the research by detecting the color of the cornea for the blind people. We have the contact with the Thammasat University Hospital to detect and collect all the data and get information with the generating the color modeling. And then the challenge point of this research is the lighting condition and also the calibration technique of the color model. So here it is. When we the upper one is the blind people when they have the gray color. So we try to matching the color of the eye here so we can paint the ink into their eye. Similarly for both left and side color. For our ongoing process, which is working with the Japan Advanced Institute of Science and Technology in Ishikawa, Japan, is the detecting the main pancreatic duct model. As we know that the pancreatic cancer is very rare, so it is very hard to get the case study from the hospital. So we have to create like a jelly model like this and put the tube inside, and it's shown as the pancreatic duct. And we will use the ultrasound to scan and get the model and learning from this image to the deep learning model. So let's see for the pancreatic cancer, it is the fifth ranked worldwide of the cancer in the world and fourth ranked in the US. In Thailand, even if it's not in the top 10 rank, but the mortality rate in Thailand is very high, up to 99.13%. It just means that the patient, when they have the pancreatic cancer, within the progression within 6 months to 5 years, the mortality rate is almost 100%. So it is very serious and it's very important if we can detect this disease before it's progressed in the advanced stage. So I will give you some brief introduction of the anatomy of the pancreatic cancer on the right side here. The yellow one is our pancreas located in the middle of our body. So it can be separated into 3 parts, the head part, body part, and tail part. So, and it's connected to the duodenum, which is our colon, which is related to our digestive system. The green one is gallbladder, and the green line here is the common bile duct, which is connected to the duodenum as well. Our challenge point on the early stage detection is the size of the cancer or tumor is very small. Sometimes it's less than 1 centimeter, and it's also in a deep layer or in our body. So it is one challenge point that we cannot just use the ultrasound image to detect this one because the size is too small, and there is no early warning sign. The early warning signs can be just only when the lucky patients have the tumor at the head part of the pancreas. So they will have some effect with the common bile duct, the green line that I showed on the picture previously. The effect can be like our skin will be turned yellow like that. The next trend is using just only the imaging sometimes is not enough. Just only one imaging, so we have to combine all techniques together. And sometimes they also need to use the tumor marker to analyze this as well. So our aim of this project is to generate the automatic screening for the rare cancer, especially in Southeast Asia countries. And we focus now on the pancreatic cancer to expand the capacity of the current diagnosis of the rare cancer by integrated all multimodal sensors together. This is the example of the medical image in both 2-dimension, 3-dimension, and it can be dynamic and static images. From the CT scan, MRI, EUS, they have their own benefit for each technique. Then we try to combine all these techniques together and get the finding to create the multimodal integration to build a unified platform that can maximize the detection rate under the limited resource in Southeast Asia country. Also the case of the pancreatics as well. The plan for connect this project. So we are open for the medical image and the signal team as well, because in the medical imaging is consists of both structured and unstructured data. Just only the biosensing or some signal from the ultrasounds can be used as the analytics information as well, and connected to the AI technology to create the support system in the healthcare and be able to establish the sustainable international relationship between Southeast Asia countries. And in the end, we believe that everybody's life is really vital. So everyone should have a life that living up to 100 years and beyond. So thank you very much for listening. So anyone have any questions?
Yes, thank you very much for your presentation. We have a question from Dr. Tony.
Yeah,
Please.
okay. Thank you for the opportunity to ask questions again. So, Prof. Pikul,
Yes.
from Thammasat, Thammasat University.
Yes.
This is from Thai-nichi.
Thai-nichi. Well, I was working at King Mongkut, North Bangkok for 4 years. So, okay. Anyway, the question is, how do you get the data? Is it a real-time data or is it from public domain data or something like that?
Right now, we are trying to search for the open source data as well, but now we have the connection with the Thammasat University Hospital, and the medical doctor can provide that information to us, but maybe we have to wait for sometimes because the pancreatic cancer is very rare and it's very hard to get that information from all patients at the same time.
Yes, because of the privacy policy or something like that.
Yes.
Okay. Can I ask a bit further? How many data do you have already?
Now we have the video recording from the ultrasound, but that one is the one that we use the jelly box. The one that we generated synthesis by using the jelly box as I showed on the slide with the Kongthon University. For the real images, we have some of the CT image, but
how many? How many CT images?
Around now is around 20.
Okay. Thank you.
Because the case in the hospital maybe just only around 20 cases per year.
Yeah, thank you very much. Now I understand. Thank you.
Thank you.
Any other comments or questions from the floor, from the audience? Okay, yes, please.
I like to give some comments.
Yes, please.
The success of the model must depend on the quality of the input, correct? Must be correct. Yeah? So in that case, right, if the process that can take advantage of the image or some other input, which might be into the 3D, that should enhance the quality of the model, right? So I think that should be what we are looking for.
Yes, it's very important. Thank you for your comment.
Okay, I have one question from myself. I believe that another important part is, for the doctor, the expert that can help you tag or annotate your data, to be able to train your AI model later. I think that's another one that you should, find. Like you said, you have collaboration with the Thammasat University Hospital, and then I think you should pinpoint or, get together with a doctor who can help you, annotate the data, collect more data, and then help you, with the training of the AI model. So that's just my comment.
Yeah. Thank you very much. It's very informative comment for me. Thank you.
Any other comments from the audience? We still got times, I think. Okay. Maybe not. Okay, so I'll just ask another one more time, one more question. So you like the title is rare and sorry, I forgot. So yeah, but then you want to first specify on the pancreatic first, right? But then maybe later on you have the option to expand to another rare and neglected type. Okay, but right now the data that you have is for the pancreatic cancer.
Right, yes.
Okay. Okay, thank you very much.
Thank you.
Okay, I think then we can move on to our next presentation. So thank you, the presenter. So for the last presentation of our session is going to be presented by Associated Professor Dr. Norhana Arsad from the National University of Malaysia. And the title is going to be Alpha Prototype Face Mask with HEPA filter and oxygen sensors. So please, I'll give the floor to you.
Thank you and good afternoon, Dr. Alisa. Dr. Alisa, can you hear me? Okay.
Yes, I can hear.
And yeah. Oh, wait.
But I didn't see
sorry,
the slide.
I forgot. I forgot to share mine.
Yep. Okay, now I can see your slide. Okay, yes.
Okay. Okay, let me start again. Okay, good afternoon, Dr. Alisa and all panels. My name is Norhana Arsad and I'm from the National University of Malaysia. And my project title is Alpha Prototype Face Mask with HEPA filter and oxygen sensor. With my team member, Prof. Jennifer Chua from Mapua Institute of Technology Philippines and Ms. Indra Herman from Institute Technology Bandung, Indonesia. This is the outline of my presentation, which consists of introduction, problem statement, objective, methodology, and finally conclusion. As we all know, for the past 2 years, our life has been overwhelmed by COVID-19. And COVID-19 is a coronavirus disease that appeared in 2019, and the case was first detected in China. It's also identical to severe acute respiratory syndrome coronavirus. It is a type of airborne virus that can spread through small droplets of saliva in a similar way to the cold and influenza and transmit as we speak and spread. In addition, it can also be spread indirectly via surface that has been contacted by bodily fluid of someone who is infected with the virus. COVID-19 brings many impact on global economy and society, causing sudden halt in business operation, disrupting supply chain, and inevitably causing job losses. In order to contain it, World Health Organization recommends following certain procedures such as wearing face masks, social distancing, sanitizing hands, and always keep good hygiene. Therefore, a prototype of face mask with HEPA filter and oxygen sensor is to be developed, besides to make sure there is always sufficient oxygen provided when wearing face mask, and last, to prevent the virus inhaled by humans when wearing face masks. For the problem statement, why do we need these prototypes? This is because, according to the graph, we can see that the number of COVID-19 cases still running at high, although most people took vaccination. In addition, local manufacturers prefer exporting their face masks to other countries to make better revenues, causing short of supply. Problem statement number 2. Besides, medical worker needs to wear multiple number of face masks 7 days a week, 24 hours a day, which take a lot of clean masks and make a lot of waste. During the times of wearing it, evaporation developed inside the face mask, and this reduced the size of many respiratory particles happen in the face mask, which cause discomfort and suffocation. Lastly, for those self-quarantine people also need to wear face masks all day and need to check their oxygen level SpO2 every day. This is the range of blood oxygen saturation SpO2, which 95% to 100% means that red blood cells are well oxygenated and sufficiently transporting oxygen around the body. While if 91% to 94% means needs to monitor closely, and if less than 90%, this will be dangerous and should consult with doctor. So next, we will talk about the methodology. This is the flaw of the mechanism of this prototype. By using HEPA filter to filter out the microparticle, viruses, and bacteria with oxygen monitoring system to make sure the blood oxygen saturation SpO2 is not less than 95% when we are at outside hospital or self-quarantine. For the HEPA filter is an abbreviation to high efficiency particulate air filter, which with a great capacity to filter out the small particles such as germs or viruses. Besides, it can remove more than 99% of the particles from air that pass through them. In addition, HEPA filter is a good help for people with asthma, allergy, or those who suffer from respiratory problems. With an example of a product with air purifier with using HEPA filter, when air purifier absorbs the air, it passes through the HEPA filter and release clean air into the room. This proves that the HEPA filter is composed of a mass of randomly placed fiber, so it can easily remove pathogen larger than 0.3 micron. For the oxygen monitoring system, this system is planning to build up with Arduino and oxygen sensor, which we will use MAX 3100 sensor, which will attach at the ear loop to collect the oxygen level. The sensor is safe to use since its main application is for medical monitoring devices, fitness assistant devices, and wearable devices. This of 2 LED optimized optic and low noise analog signal processing to detect pulse and heart rate signal. So how this sensor works? When the heart pumps the blood, there is an increase in oxygenated blood as the heart oxygenated pieces. So by knowing the time between the increase and decrease of oxygenated blood, the heart rate is determined. So this sensor also can connect to Bluetooth system so that people can always check their SpO2 level when they wear face masks. Okay, we come to the last slide. The conclusion, I would like to conclude that the MAX 3100 sensor and HEPA filter will be used to build this prototype. Since both of this material can be used to reduce the use of face masks, help victims of pandemics can get medical help immediately when their SpO2 level is less than 95% and reduce the risk of by virus. But there is also a challenge in this prototype, which is classification of COVID-19 or other disease related with low blood oxygen level, such as heart disease. Thus, I end my presentation with thank you. Okay, Alisa.
Thank you. Yes, thank you very much. So now I would like to give the floor for the audience for any comments or questions. I'll start first while other are still asking later maybe. Just wondering like the first one is this the mask with the HEPA filter? Is it already available in the market? Like, is there the products that's already just combined, you know, like using HEPA filter with the face mask?
Okay, thank you, Dr. Alisa, for the question. Actually, we have a collaborator, for example, Indra for the ITP. She is in the field of additive material. So from there, we will build our face mask with the material, additive material to produce the face mask. And together with me, Prof. Jennifer also expert in the IoT, for example, and then we will connect the oxygen sensor with the IoT application so that everyone can monitor remotely their children or individual, freely.
Okay, so another question, when you say the IoT, the sensor would attach to the earlobe, right?
Yes.
Is that the place? Is that the place is good place to measure the oxygen? I mean, I use the oxygen measurement thing with the finger, right? Like I saw that people use it for the finger, but then with the earlobe, I mean, is that the best position that, you know, can detect the oxygen level from the earlobe?
Yeah, from so far from the research, we have seen that or read that from the from many paper reported that we use the earlobes to collect the levels, the oxygen level, because normally we will put on our hands, right? So, but we will feel uncomfortable because we always use our hand to eat and then for writing. Meanwhile, for the earlobes, is because it's very easy to attach something like our jewelry, right? So I think it will less discomfort for the user.
Okay. All right. Are there any questions from the floor?
I have a question.
Yes, please.
I was a little bit interested in the system diagram after the statement from Dr. Norhana about using IoT and the oxygen sensor. So how do you connect the oxygen sensor and IoT?
Okay, so we have the Bluetooth. We will have the Bluetooth, and then it connect to our phone. And then for our phone also, we upload our data to the cloud, and then everyone can monitor their level of oxygen.
Okay.
So it's a smart device, actually.
Oh, via the smart device.
Yes.
Oh, okay. Okay. Thank you.
So currently, what we have, what we have now is face mask can detect how many germ on the face mask, and then so we are going to for the IoT, the system, the cloud, also ready. Just we want to integrate and then see how it works.
Okay. And how often do you have to clean the mask with the HEPA filter? Like, is it one time use, you throw it away, or you can reuse it, or you can clean it?
For this one, yes.
You can
reuse it, yeah.
Oh, okay.
Because one of the pollution and waste pollution because we can see that many face masks thrown away everywhere, and then it's a waste that we have to clean our environment with this approach.
I see. Okay. Any other comments? We still got a few minutes for the comments or questions or any input. Maybe I'll ask another one, like one last one for me. Just wondering, like, do you consider this, or like say in Malaysia, right? Do you consider this as the medical device? Like say if you have it as a product, and I think say for example in Thailand, to be able to register as the medical device is, you know, a lot of process. You have to go through a lot of like, you know, FDA, you know, the Thai FDA and a lot of things. So how about in your country? Like if this is considered as the medical device, how long is the process, or do you know, like, you know, like the process, is it hard or is it easy?
Yeah, I think it's a little bit hard actually, the process, because we have to get approval from many departments, and then one of our collaborator now we are in a discussion with Institute for Medical Research Malaysia, and then they are testing the face mask that we developed, and then we are waiting for their response and feedback how this face mask can be used particularly for the frontliner, because they are the one who will use all this PPE, and to make sure that the oxygen for the frontliner also not less than 95%. Thank you.
Okay. I saw Professor Tony Anwar raised a hand. Can you just give a quick comment? Or
thank you, Dr. Alisa from NECTEC. So, what is actually your product? I am still a bit confused, because oxygen sensor is there, IoT is there, cloud computing is there, face mask is also there.
Yes,
the face mask with the oxygen monitoring.
sensor. Yes, monitoring. Yes.
Okay, that is your product, right?
Yes.
Okay. Thank you. Yeah.
Thank you.
Okay, thank you for all the comments. I believe this is the last presentation for the session on ICT for health and welfare. So thank you everyone for the participation, and I would like to conclude the session, and we can take 5-minute breaks before we start the next session. Thank you very much.
Thank you.
Thank you, Dr. Arisa and the speakers.